Good afternoon. I'm Kate Ellis, Vice President at the National Institute for Healthcare Management Foundation. NICM is a nonprofit, nonpartisan organization dedicated to improving healthcare through evidence and collaboration. I would like to thank our audience and our panelists for joining us today for this important discussion on the aging population and managing health and costs through Medicare Advantage. By 2050, nearly 1 in 4 Americans will be 65 years or older, placing an unprecedented strain on Medicare and the broader healthcare system. Much of the growing financial pressure stems from the increasing prevalence of chronic diseases in older people, including diabetes, heart disease, and dementia, which require ongoing, resource-intensive care. Today, we'll hear from a panel of experts to learn more about the trends related to the aging population and strategies implemented by Medicare Advantage organizations to support the health and well-being of older Americans while also managing the cost of care. Our panelists' slides, their bios, and today's webinar agenda are available on NICM's website for anyone interested, and these materials will also be posted in the Zoom webinar console. I am now pleased to introduce our first speaker, Dr. Karen Hacker. Dr. Hacker is an adjunct professor and policy fellow at the Emory Rollins School of Public Health and an adjunct professor at the Morehouse School of Medicine. She is a well-respected public health expert with extensive experience, ranging from local and federal positions, including previously serving as the director of the CDC's National Center for Chronic Disease Prevention and Health Promotion, where she led the nation's efforts to reduce chronic disease rates. We are honored to have her with us today to help set the stage on the health of the aging population. Karen?
Thanks so much. Can I get the next slide, please? So as Caitlin said, I'm really here to set the stage and give you sort of an overarching view of what's happening with our population here in this country. And just to give you a sense, we're really in an era of absolutely dramatic demographic shifts. The United States population hit a median age of 39, which may not seem that high, but that is a record high. We've got this aging baby boomer population. And so the percent of American population that's over 65 is expected to reach 25% of the United States population by 2040. That's 80.8 million people. Now, simultaneously, we are also seeing a decrease in the younger population as birth rates have been declining. Next, please. This is a lovely way of sort of thinking about the shift that's going on in the proportion of population. As you can see, between 2000 and 2020, we're starting to see a really big change in where the majority of the United States population sits. So between 2000 and 2020, the over 65 population grew by 12.4%, in 2004 to 18% in 2024. Next, please. And as the aging baby boomers go, and I can consider myself one of those, thanks in part, I would like to say, to public health and better conditions like vaccines and treatments, they're also living longer. So life expectancy at 65 years of age for both sexes is almost 20 years. For males, it's about 18.2 years, and for females, it's about 20.7 years. So that means we can expect to see the 65 population, they're going to be around, hopefully active, for another 20 years. Next, please. Now, at the same time, over the years, we've seen a major shift in the causes of morbidity and mortality. At the turn of the 20th century, the major causes of death in this country were still from infectious diseases. But we witnessed what's often called an epidemiologic shift in the early 1900s when chronic diseases became the leading causes of death and disability in the United States. As the population ages, we are also seeing, as a result, more chronic conditions. Bottom line is, age is the major risk factor for chronic disease. We're seeing more adults with multiple chronic conditions. And in 2018, about 27% of adults in the US had more than one chronic condition. So here are some of the major chronic conditions that we're talking about. And you can see that obesity is really a major chronic condition that is a precursor to almost all of the other chronic conditions that we're talking about. Certainly diabetes, hypertension, And with the increasing rates of obesity that we have seen since the 1970s, the contribution to chronic diseases continues to be absolutely paramount. We noted, and I heard from a colleague recently that she said obesity was a great accelerator of aging. Next, please. An interesting study by Ansa and Chu recently, they noted using a multi-state population model, estimating age, gender, and race-specific transition rates to project future chronic disease burden. You can see that the results of these curves demonstrate trajectories from one state, either healthy, one chronic condition, or two or more chronic conditions, to another state. And in general, there's an upward trend from 50 to age 80. By 2050, most Americans of all races and genders will have at least one chronic health condition. Almost 95% of American adults age 60 and older have at least one chronic health condition, and about 79% have two or more already, according to the National Council on Aging estimates. And with the projected growth, the number of people aged 60 to 79 with chronic conditions, we're expecting it to grow by nearly 80% by 2050. And while the number for those 80 or older is expected to grow by more than 200%. So the growth is expected to outpace overall population growth in these age groups. Next, please. Now, as we think about the growth of chronic diseases, let's look at a recent analysis of something called the Behavior Risk Factor Surveillance System, which is actually a very important surveillance system used by the Center for Disease Control and the rest of the nation to estimate self-report of chronic conditions in particular and multiple behaviors. And as you can see here, there is a rise in increased comorbidities, and it's actually noticeable in all of these populations. Next, please. And if we look at specific trends in chronic conditions, you can see the rise of obesity in particular and the concomitant amplifier that it has on many chronic conditions, particularly if you think about this 35 to 64-year-old age group. And that means that those people will be entering their 65 and over stage with additional chronic conditions. Next, please. Now, I just wanted to talk specifically about one chronic condition because I think that Alzheimer's is expected to grow so substantially. And I think we all know what the impact of that is on healthcare, on caregivers, and it is expected to rise substantially by 2060. Next, please. So as we think about this enormous shift going on in our population, and I do believe to a certain extent that demography is destiny, what are the implications of these changes? And there are major policy issues that we are going to be hearing more about today. Medicare, obviously, Medicaid, what happens with caregivers, Social Security, and then something that we call the social determinants of health or the non-medical factors that affect health. And those include things like transportation, food security, housing, and economic stress. Next, please. So certainly trends in healthcare. Now there are people who are spending high spending at all ages, and we know that overall healthcare spending is increasing because of the cost of healthcare, but also because of the number of people over 55 who are using the healthcare system. And we've seen that spending has been increasing despite and the population over 55 in particular, despite they only making up about 31% of the population. People under the age of 35 make up a higher portion of the population, but are only responsible for about 23% of the spending. And then people with significant health needs account for such a large portion of the total healthcare spending. Those who report a poorer health status, they account for 11% of the population and over 27% of healthcare spending. Next, please. I think generally people assume that we're talking about Medicare, and clearly we are talking about Medicare, but Medicaid is a big contributor because it does cover long-term care services for populations. And Medicaid paying for those long-term care services particularly for those with low incomes, also helps to cover some of the Medicare out-of-pocket costs. So as a result, those over 65 are accounting for about 10% of total Medicaid enrollees, but 20% of its spending. So looking ahead, Medicaid may not be keeping pace with the rising demand for the long-term services that are needed, and that heavier burden may fall then on family caregivers who are going to have to deal with those unmet needs. Next, please. And I just want to do a shout out because I think the area of caregiving is something that is really going to be increasing. Who's going to provide that caregiving? How are they trained? If it's not a family member, how are family members able to cope with this? What does this mean for financial stress in a family? There's just so many issues, I think, related to caregiving. Next, please. So as we also think about these social determinants of health, as I noted, these non-medical factors, all of these things we have to be thinking about as we understand these demographic shifts. First of all, just people who are aging are going to be using transportation, will have different kinds of transportation needs, issues of food security, housing, economic stress, and issues of isolation, which we know contribute to healthcare outcomes. In general, the people with chronic conditions that we saw in a study we did recently using information from the behavioral risk factor surveillance system and in particular a social determinant of health module, we noted that people with chronic conditions were more likely to have more social needs or health-related social needs, as they're often called, than those without any chronic conditions. I think this makes sort of implicit sense, but again, it just notes that. Think back to the slides I showed earlier where we have this growing population with more than one chronic disease, also likely means that they're going to have more need for some of these areas and specialized services in particular to support those needs. Next, please. So just giving you a few take-home points as we listen to the next two presentations, thinking about this unprecedented demographic shift that we're seeing in the United States. And by the way, this is not solely the United States that's experiencing this, but a lot of the Western European countries are also seeing this demographic shift, that we know that age in and of itself is a major risk factor for chronic disease. We see that the chronic disease burden is growing simply because age is a major risk factor. We know that our growth in obesity has been and continues to be an accelerator of aging, contributing to numerous different chronic conditions. We see the cost of care growing due to the aging population, but also notably the increasing cost of healthcare. And then lastly, thinking about how these social determinants create additional challenges for this shifting population and how much of that burden now falls upon the healthcare delivery system to think about creative strategies for addressing these social needs. I think you're going to hear a lot more about that from our two speakers that are coming after me, and I will be around to answer questions at the end. So I'm going to turn it back to you, Kat.
Great. Thank you so much, Dr. Hacker, for helping us set the stage on the trends in the aging population and the roles that social determinants play in addition to the role of Medicaid. Next, we will hear from Jennifer Kowalski. Jennifer is the Vice President of the Elevance Health Public Policy Institute. The Public Policy Institute works to advance meaningful change in the healthcare system through the publication of policy-relevant data analysis, timely research, and insights from Elevance Health's innovative programs. In her role, Jennifer conceptualizes and drives the execution of data-driven health policy analysis and health services research. She brings extensive expertise to this discussion, and we are grateful she is with us today to share more about how Elevance Health is working to improve health for its members and address the rising cost of care. Jennifer?
Thanks, Caitlin. You can go to the next slide, please. So to level set, I'm sure you're familiar with the Medicare Advantage program, but I wanted to show how the growth in MA has sort of accelerated over the last decade or so. Today, Medicare Advantage enrollees comprise about half of all Medicare enrollment, and the share of beneficiaries in MA is expected to continue to grow. And there's many reasons I think that Medicare Advantage plans have become an attractive alternative to the traditional Medicare program, some of which are the additional benefits and chronic care management programs that the plans offer, which I'll touch on some as well as Kortney will after me. But then, of course, there's some trade-offs with the plans as well. Medicare Advantage plans come with a more limited network. They come with some more utilization management programs than the traditional Medicare program does. And at the same time that MA has been growing in popularity, there's also been more interest on the part of policymakers and stakeholders to really understand what is the value that Medicare Advantage plans are bringing to enrollees. And that's to some extent where the Public Policy Institute and the work that we've done has been able to come in to look at what's been the value specifically of some of the supplemental benefits that are available through the Medicare Advantage plan. So next slide, please. So what are Medicare Advantage supplemental benefits? So Medicare Advantage plans have to provide all of the same benefits that traditional Medicare or Medicare fee-for-service, depending on what you'd like to call it, does, but MA plans are often more efficient at providing those services, and they're able to use the savings that they generate to offer extra benefits to enrollees. And this can take the form of reducing the cost sharing that's inherent in the traditional Medicare package, so deductibles and coinsurance and things of that nature. It can also take the shape of enhancing the Part D drug benefit, but it can also include extra benefits that aren't part of the traditional Medicare package. So you might think of things like vision benefits and dental and hearing benefits. But more recently, in particular, it's included things that address those health-related social needs that Karen was talking about. So things like transportation and grocery benefits, healthy food benefits. And these extra benefits can really go a long way in helping to meet members' health and social needs. So it can help to improve chronic condition management, it can help improve access to care, can help improve outcomes for our members. And today I'm going to share some high-level findings from a few studies that we've done to really dig in and understand how these supplemental benefits are affecting the outcomes for our members. So next slide. So we started this research a couple years ago with really a kind of a high-level descriptive question, which was just to simply understand at first, are our Medicare Advantage members, are the enrollees in our health plans using these supplemental benefits that are available to them? And in this case, when I'm talking about the supplemental benefits, I'm really talking about those extra benefits. So the vision, the dental, the hearing, the transportation benefits, and so forth. And in 2022, which was the data that we had available when we started this work, we see that the vast majority of our members are using at least one, if not more, than one of the supplemental benefits available to them in their plans. And on the left-hand side of the slide here, you can see that amongst our dual eligible members, and these are folks who are eligible for both Medicare and Medicaid, they are about 2/3 of them, 64%, were using two or more supplemental benefits available, as opposed to about half of the non-dual eligible members on the right-hand side of the slide who were using two or more of their available supplemental benefits. The other thing that we found in this study that's not shown here is that members who lived in what I would call sort of under-resourced areas like food deserts or areas of lower socioeconomic status were also more likely to use supplemental benefits. Next slide. So then, kind of knowing that our members were taking advantage of and using these benefits that were available to them, we wanted to dive in a little bit deeper and ask the question, what association is there between use of these supplemental benefits with utilization of other healthcare services? So inpatient visits to the hospital, office visits, and preventive services. And we included members who used at least one, if not more than one, supplemental benefit in 2021 and or 2022. And again, we looked at our dual eligible members separately from our non-dual eligible members. And before I move on to the next slide, just a quick note. I know Caitlin shared all of the slides with you. There's links to each of the reports that I'm going to talk about in the slides. So I'm not going to spend a lot of time on the specifics of the methods or the data. It's all in the reports, but I'm also happy to take questions at the end if you do have any specific follow-up questions. So next slide, please. So in this particular study, overall, we found that use of Medicare Advantage supplemental benefits was associated with more favorable healthcare utilization. So let me just kind of walk through what this graph is showing for a moment. First, I'll note that the dark blue bars are for our non-dual eligible members, and the bright blue bars are for the dual eligible members, the supplemental benefit users. And the solid bars show statistically significant results, and the hatched bars are not statistically significant. So if you look at that first set of bars there that's labeled inpatient admissions, that bright blue bar that shows negative 14%, what that shows is that there is a 14% smaller likelihood amongst our dual eligible members of having an inpatient admission if they used one supplemental benefit or more versus if they hadn't used any supplemental benefits. So notably, the results don't compare users to non-users or users to the fee-for-service program, but really compare supplemental benefit users to themselves under an alternate scenario where they hadn't used any supplemental benefits. So again, we see a decreased likelihood of having an inpatient admission from use of supplemental benefits. And then continuing across the graph, we see no effect on ER use, but we do see that there's a greater likelihood of having an annual wellness visit, as well as a PCP office visit or a specialist office visit that's associated with using supplemental benefits. And then an even greater likelihood of having a cancer screening. We looked at colorectal cancer and breast cancer screening, as well as cholesterol screening from using supplemental benefits. And across all of these findings, you can see the bright blue bars are larger than the dark blue bars, meaning that the results are even more favorable amongst our dual eligible members, which I think to some extent kind of aligns with our previous findings that dual eligible members were using more of these supplemental benefits. And, we've thought a lot about, what's driving these findings. Obviously, these are pretty broad. We're looking at a pretty wide set of supplemental benefits. We're looking at a number of different types of healthcare utilization. So we have a few different hypotheses, and I think probably any of them could be applicable to, some of these findings. First being that some of our members may have used the transportation supplemental benefit, which may have improved access to get to some of these visits. It also may be that some benefits like the healthy food, for instance, could improve management of chronic conditions, which might keep members out of more costly inpatient admissions. It could free up limited income or resources for some of our members to be able to pay for copays, for instance, to get some of these needed visits. There could also be a bit of a kind of snowball effect here where maybe transportation gets members into the annual wellness visit, but while they're there, the doctor reminds them they need a breast cancer screening or actually performs the cholesterol screening. And then even though we have made a lot of attempts in this research to control for selection effects and other factors like that, it could also just be that some people are more engaged in their health generally than others. And so the same people that are, more likely to get some of these screenings are also more likely to take advantage of all of the benefits in their health plan. Next slide, please. So from there, we wanted to dig in a little bit deeper into some of the outcomes associated with specific benefits. So, rather than kind of looking at use of any of the benefits available, we decided to focus in on the grocery card benefit. And after vision and dental and some of those benefits, the grocery card was one of the more well-used benefits amongst our supplemental benefits. And for those not familiar, grocery cards provide a monthly allowance for folks to purchase groceries. Sometimes also that includes things like over-the-counter items, so Advil, Band-Aids, that kind of stuff. And one of the other reasons that we chose to focus on the grocery card benefits to start is that there's a good amount of literature that shows the connections between food insecurity and having more health conditions or having more costly patterns of healthcare utilization. And I think Karen talked about some of that as well. And also individuals who have food insecurity are less likely to have a usual source of care. And so our hypothesis here was that by providing grocery benefits and addressing food insecurity through the grocery card, that in turn, we could start to address some of these negative patterns of healthcare utilization. So we could free up resources for people to seek care that they needed, or even just kind of reduce some of those stressors associated with meeting things like food security and allow folks to have the ability to focus on other needs like healthcare. So this particular study, we focused in on dual eligible members who are enrolled in dual eligible special needs plans, which are plans that have enrollment limited to people who qualify for them by being eligible for both Medicare and Medicaid. And we actually had introduced this grocery card benefit on January 1, 2022. So we looked at individuals who were continuously enrolled in these plans from 2021 through the end of 2022 so that we could compare their utilization prior to and after use of the newly offered grocery card benefit. And we compared folks who used the benefit to those who did not, as well as individuals that we call frequent users, meaning they used more than half of the allowed amount, to non-users. And 99% of the folks in the sample had a benefit of $50 per month. Next slide, please. So what we found here was that the use of the grocery card amongst our dual eligible members was associated with an increased likelihood of an office visit, increased likelihood of an annual wellness visit, PCP visits, and specialist visits, as well as an increased number of office visits and specialist visits as compared to non-users of the grocery card. In the chart here, the dark blue bar are the grocery card users, and the brighter blue bar are the frequent users, so those who used more than half of the benefit. And so, for instance, if you look at the first set of columns there, you can see that both users and frequent users of the grocery card had an 8.7% greater likelihood of having any type of office visit as compared to non-users. You can see that the results for the frequent users of the grocery card are generally similar to the outcomes for the overall use, any use of the grocery card, though the magnitude is slightly bigger. So for instance, under the annual wellness visit, frequent users had an 8.4% greater likelihood of getting their annual wellness visit as compared to the any users, which was 6.6%. I think in general here, our findings align with some of that literature that I mentioned on the last slide, kind of showing that addressing individuals, kind of basic but potentially unmet needs like food security can help relieve some stressors that maybe allow them to focus on their healthcare needs a little bit more fully. Next slide, please. And then from there, we spent a lot of time looking on the last two studies at what was the association between use of these benefits and use of other healthcare services. But what we wanted to dig into next was to what extent did that impact member outcomes or healthcare quality? And so we wanted to look at use of two different benefits. Again, the grocery card benefit, but here we also added a transportation benefit, which includes both non-emergency medical transportation, as well as sometimes transportation to non-medical services. So you can think of that as, a ride to the grocery store or a ride to the senior center, for instance. And this study also looked at dual eligible members in our DSNP plans. And you can see in that smallish table down on the slide there, we focused on three different groups of measures. So we looked at one measure around the annual planned visit that was applicable to everyone in the plans. And then we looked at two sets of measures for our members with diabetes and our members with cardiovascular conditions. And some of these are outcomes measures, so blood pressure control, for instance, and then some of them are more process measures like adherence to statins. Next slide, please. And, I'm feeling like a bit of a broken record here, but the results are somewhat consistent in that we see that our dual eligible members who use these benefits, both the food benefit and the transportation benefit, And on the slide here, the food is in the dark blue and the transportation benefit users are in the brighter blue. And so that we see that the members who use these benefits had greater odds of meeting, if you will, these HEDIS quality measures as compared to non-users. And we see that the results are kind of greater magnitude for food benefit users as compared to transportation benefit users. And potentially, we did look at two conditions here, diabetes and cardiovascular conditions, that I think are fairly sensitive to diet, and so that may be why there's kind of more of an impact here. But if you look, for instance, at the HEDIS measures for members with diabetes, you can see that for our food benefit users, they had a 45% greater odds of maintaining HbA1c control as well as blood pressure control as compared to non-users. And then moving over under cardiovascular conditions, about a 35% greater odds of controlling high blood pressure, as well as adhering to statin therapy. And you can see that for transportation benefit users, we see the two highest results are for having an eye exam and for kidney health evaluation. And these are in-person services. So, I think that also makes sense that we are seeing that, having a way to access care increases the odds of getting those services met. So let me turn to the next slide. Caitlin, do I have a minute to continue?
Yes, you are good. We're ahead of schedule.
Okay, great. So before I hand the floor over to Kortney, I just wanted to switch topics a little bit and talk more generally about Medicare Advantage's impact on overall program spending in the Medicare program. And over the last 15 years or so, MA enrollment, as I mentioned at the start, has doubled from about a quarter to about half of the total Medicare population. And over that same time frame, we've actually seen total Medicare spending be lower than what was projected. So when you think about the Congressional Budget Office or the CMS Office of the Actuaries that kind of project out spending and what they think it will be, that blue line here on the graph is what CBO thought spending would be from 2010 to 2020. And the orange line is what it actually was relative to the projections. You can see that it's a bit below, and there's been a lot of hypotheses about why this might be, and this is per capita spending. So there's been a lot of hypotheses about why this might be, particularly with growing burden of chronic disease and so forth. Some of it is that we've got a lot of really good generic and less expensive medications to address chronic conditions like hypertension and high blood pressure. Some have thought that the payment and delivery reforms that were instituted in the Affordable Care Act may have had some impact here. What we wanted to look at was how did the doubling of the share of people enrolled in Medicare Advantage have an impact, if at all, on the trends that we're seeing in spending. So if you turn to the next slide, I'm not going to go into a lot of detail here, but happy to answer more questions later. But we looked at two different questions. One, comparing across counties. How did higher annual MA penetration, or percent of people enrolled in MA, did it have any association with the change in total Medicare spending? And then secondly, within a county, did the year-over-year increase in MA penetration have any association with the change in total Medicare spending in that county? In both cases, you can see we have a sensitivity analysis listed here. We adjusted the Medicare Advantage risk scores to account for what MedPAC refers to as coding intensity that has been unadjusted for in MA payments, just to see if that made any difference. And then what we found was comparing across counties for a 10 percentage point higher annual MA penetration, we saw a 1.9% lower total Medicare spending. And within a county, for a 10 percentage point year-over-year change in Medicare Advantage penetration, we saw total Medicare spending per capita decrease by or have a lower increase in about 1%. And we calculated from these numbers a rough savings estimate, comparing it to if Medicare Advantage penetration had remained at the 2011 level, which is about 28%. and found savings of about $59 to $144 billion, depending upon which estimate you use here, which is doesn't explain all of that gap in the prior slide, but certainly explains some of it. And some of this may be driven by what other researchers have pointed to as the spillover effect from Medicare Advantage into the traditional fee-for-service Medicare program, meaning that as Medicare Advantage becomes a larger part of the program in a particular area, and therefore a larger part of providers' patient panels, the incentives that MA puts in place for care coordination to encourage providers to manage care and to reduce use of low value care or things like expensive imaging, those things flow through to how providers treat all of their Medicare patients. And so you see fee for service start to benefit from some of those chronic condition management and other tools that Medicare Advantage institutes. So just to kind of sum up, before I pass it back to Caitlin, we're excited to share the research today, so I thank you for having me. Hopefully, you can see that from a plan perspective, there are many things that we're doing to both improve outcomes for our members and for beneficiaries that choose MA, as well as to provide value to the overall Medicare program. So, Caitlin, I will turn it back to you.
Great. Thank you so much, Jennifer, for sharing the role of supplemental health benefits and improving health outcomes, highlighting the value of focusing on issues like food insecurity, and walking us through the findings of your research. Next, we'll hear from Kortney Cruz. Kortney serves as the Senior Vice President of Government Markets at Independence Blue Cross. She provides overall leadership to IBX's Medicare businesses, including operations, sales and marketing, risk analytics, and performance management, as well as oversight of the company's Medicare Star Ratings initiatives. While at IBX, Kortney helped launch the company's Age Fearless initiative to engage and educate individuals 55 years and older on holistic health and well-being. It is great to have her with us today to help us understand the approaches that IBX is taking to support its aging members and their caregivers. Kortney?
Caitlin, thank you for having me. I think we can move on to the next slide. And just to give a little bit of a sense of who Independence Blue Cross is. And first, actually, let me take a step back and thank both Karen and Jennifer. Karen for doing a wonderful job of setting up demographic trends, and then Jennifer for really laying out an understanding of the framework of the Medicare Advantage plans, how they work, how supplemental benefits come into play. Independence Blue Cross is a health insurance carrier that is focused on Medicare Advantage. We have been in Medicare Advantage for a number of years, since the very beginning, actually. We have around 120,000 members in the 5-county southeastern Pennsylvania area. So we are a very focused community-based organization that has a long legacy in supporting our community overall, but also seniors specifically. Go to the next slide. And so healthy aging for us is a central part of our mission. If you think about Pennsylvania as a state and the Northeast in general, we definitely see the aging demographic, and I think I might steal the phrase, I just grabbed one from Karen, the demography is destiny. We are certainly seeing that play out in the Philadelphia area. And for us, given that our central mission is to really enhance the health and well-being of the members in the communities that we serve, that goes hand in hand now with having a framework and a mindset around what it means to age in a healthy manner. And so we have, as I mentioned, one of the first demonstration age contracts with CMS that launched our PPO plans. And due to our high retention rates combined with how long we've been in the MA business, we also have a higher than average share of older members. So we have certain PBPs, which are plan benefit packages, where we have members who the average age is actually 83 on our plans. And so while we have a variety of plans we offer, we definitely see a central portion of our population is already in that older faction that we were talking about earlier in the webinar. And so thinking about how we can be on the leading edge of solutions that help our seniors age well was a critical component of our overall strategy. Slide. And so as we were talking about how we approached this, And to maybe put it in context, I specifically have been working with the Independence team long enough to remember when we were all very excited as an industry about boomers aging into Medicare. We'd all talked about the silver tsunami ad nauseum. We built Turning 65 campaigns to help educate them about Medicare, original Medicare, Medicare Supplement, Medicare Advantage, what their options look like. That is very different than where we are right now as a country, where we're thinking about what will it mean for boomers to turn 80 as they will next year, and how do those health needs evolve versus the population that was aging in not that long ago. And so we were having these internal dialogues, and I'm very very thankful that Independence has made investments in this space, including bringing on board medical directors that have a geriatric background so we can have thought leadership and conversations around how we structure ourselves. One of the first things we decided to do was evaluate what frameworks are already out there to judge how we are performing from an age-friendly standpoint. And so we really settled on using the 4 M's of age-friendly health systems, which was designed more for the provider side, to think about how are their correlations, or what are the corollaries to a carrier? How can we think about how we take the 4 M's, and for those that may not be familiar, they're featured here. I'll start actually from right to left: mobility, mentation or behavioral health, medication, and then what matters. What is a senior really looking for? It's a very kind of personalized decision, this aging process. Do I want to stay in my home or not? Do I have that type of caregiver support that was mentioned before? Or did my son or daughter move out to California? How does that kind of framework play into what I am looking for as I age? And so we've used this as our central point in thinking about supporting an elder population. Let me move to the next slide. So as we built that in, though, we also understood that we needed to build in the business principles that are a foundation to Medicare Advantage. And I won't dig too much into the business design itself. I can always answer questions once we get to the Q&A section. But we wanted to take the 4 M's as sort of the heart of the program, but also think about how does that integrate with STARS. Each Medicare Advantage plan is ranked and rated on a number of measures that feed into a star rating, averages 1 to 5. And being 4-star and above also comes with a quality bonus from CMS that can be very important in being able to invest back into those supplemental benefits and other programs and offerings that Jennifer just talked about. There's also the risk adjustment program, which, when done well and correctly, provides a fully accurate clinical picture to the member that you're supporting. That again allows the reimbursement from CMS to align with the acuity of the member that you're supporting. But then there's also the total cost of care, which I know is very much top of mind for everyone in the industry right now. How are we sustainable, and how we're offering the various support and services to this multi-chronic aging population? Right, go to the next slide. So as we were thinking about what does that mean, where do we start, what do we offer, as you're designing your products and benefits every year, there are a multitude now of different types of support programs and supplemental benefits that you could offer. In some ways, I think the growth of social determinants of health and it being a conversation point for us as an industry was a really critical component. However, it also creates challenges as you think about the total cost of care. How can we make sure we're offering things that are really going to provide that balance? Because the need is so great. As was outlined by Karen earlier, it's very easy as a health plan to chase down a multitude of rabbit holes, almost all very well-meaning, but everything comes at a cost. And so how do you decide how to prioritize? And that's where the framework that I just showed came into place. And so I want to share a few examples of some programs that by using that framework, we settled on were core places to start for Independence Blue Cross and how we think about and support our members as they navigate through the aging process. So one great example of that we introduced about 2 years ago was our post-acute care program. I know this is not revolutionary, but I think for us, it was revolutionary in that we were thinking about it not just in terms of how can we limit the total cost of care, how do we find savings, but it was also about how do we make sure we're meeting where we need to be from a quality standpoint for certain STAR measures, as well as how are we better understanding what matters to the members, particularly also what matters to the caregivers for the support and care that they need. And so, one of the things that we noticed early on is that a large percentage of our members, over 20% of our members, have a post-acute need sometime in their journey with Independence Blue Cross. So high volumes. It's also now 20% of our overall STAR ratings, partly because we do have an average older population. If you think about some of the metrics that are included in STARS, once you hit a certain age, you are no longer in the denominator for some of the gap closure measures, for example, cancer screenings, right? And so things like the readmission measures and other post-acute oriented measures and overall CAP survey, so how do I feel, back to what matters, has a heavier weighting in how we perform for STARS. And so that's why we really thought it was an important place to invest and building out a program where we do outreach to 100% of our members that have an inpatient episode. And at that time, while they're still in the hospital, work with them to make sure that they have a smooth transition to home or to SNF. We also have nurses at certain SNFs that are in particularly underserved neighborhoods or have a high volume of our members going to that SNF to ensure that we have a well-coordinated outreach and support. Through this program, we also really focused on what does it mean for our caregivers. And sometimes the caregivers were also Independence Blue Cross members. So these could be either spouses who are supporting one another, or they could be, as most people think of them, a daughter, a son who is providing that caregiving and support. That need is so great. And so as we thought about post-acute being at that moment of crisis, how do we use that moment of crisis to support the caregivers and support the members through that transition period? And then how do we forge a relationship where we can then support that caregiver longitudinally, because they provide an essential resource in the overall support and management of the member. So we worked very closely with an organization called Parallel to stand up a caregiving program. And I think we want to move forward one more time. And really providing 24/7 support, access, and resources to our caregiver, everything from coaching to advice to guidance, navigating through plans, understanding what mom or dad just went home with, really reducing their stress load and empowering caregivers. And by at first tying it in with our post-acute program, we were really able to pilot and understand what it meant at central point of abrasion or challenge, and also really just build up the business case to be able to extend it into a full program. And now 100% of our caregivers have access to Parallel support. You go to the next slide. And so Parallel is actually a great example of a supplemental benefit. So yes, most people think of supplemental benefits as allowances or OTC or other things, but supplemental benefits can also be programs that you can offer to help support the members. Another great example that we launched just recently is with Isaac Health in the dementia care space. Again, one of the conversations as we were working with Parallel, you see how all these things very much begin to tie together, and understanding what the feedback was from the caregivers that they were supporting. Dementia continually rose to the top as an issue, or at least the signs and signals that made us believe that they may be dealing with a dementia challenge, even if the member had not been diagnosed with dementia. And so for us, that became a really critical point, because as we think about what Karen mentioned around the growth of Alzheimer's, the growth of dementia, we feel that it is significantly underdiagnosed in our current population. And so that means both the member and the caregiver are not necessarily getting the support they need early enough on in order to make a difference in the long-term trajectory of that member. We also know our providers within our PA5, the Philadelphia area, are very much stressed and strained in their own right. And so we looked for partners that we could bring to the table that could provide some of the early on lift, work with our informatics team on different methods to have early indicators of whether or not someone may have dementia, and then use that to institute outreach and put together a program that is both supportive of the member and the caregiver if they have one, and really having personalized care plans that also include a virtual component, and depending on the acuity of the member, can also include some in-home resources and support. Go to the next slide. So then we talked about the 4 M's. I could go all day if necessary on the challenges of pharmacy, RX costs. Of course, there's the GLP-1s, still huge headlines in the news. But as we think about managing a chronic population, it's often important not to lose sight of some of the basic blocking and tackling. And so, if the high percentage of individuals that are over 60 that have at least one, if not two, chronic conditions, often means they're likely on some sort of medication. And so having programs that help them stay adherent are really important, not just from an overall STAR standpoint, although there are specific adherence measures in the STARS program, it's also really critical for the overall cost of care. And so this is a new pilot that we have been working on within the past few months around really identifying those that are most at risk for being non-adherent and being early on in the intervention and understanding why, how we can support them. Is it a cost issue? Are they perhaps eligible for various subsidies that might offset that cost? Is it a transportation issue? Can we sign them up for mail order? How do we get in front of medication adherence challenges before they exist or emerge? And how do we work directly with the provider as well as the pharmacy to make sure that member is getting support and care that they need? So it really is a holistic program that we've put in place, driven by AI. AI is not always bad, in order to really help our members stay adherent. And as we evaluate this program, the impact not just on the STARS program, impact on the member experience, but also impact on the total cost of care, because we are not seeing the challenges, the spikes, the ER admissions that might go with someone who is not being well managed. Final slide, just one more example, I believe. And so I wanted to include this one, even though this is not perhaps something one would traditionally think of when they think about Medicare Advantage plans. This is not a supplemental benefit. This is not a clinical program that we've introduced. This is just back to the what matters part of the M. And so we've engaged with our internal Medicare member experience team, who launched a program with an organization called Medallia that's very much about call listening and understanding what is happening with our members. What are their call patterns? What are their call trends? What are their concerns? What are the key drivers that are underlying their engagement with us as a healthcare carrier? There's such a wealth of information there, particularly with seniors. They love to call, they love to talk, but it's hard to just mine that data without having a platform or ability to leverage it. Putting Medallia in place has really allowed us to take that information and feed it back into our process of identifying what is the next best solution, what is the next best supplemental benefit, how do we alter and tailor what we already know and what we already have and exist, what are the leading indicators that we can use to inform how we move forward that we may have missed otherwise. How is dental influencing medication adherence, for example? And there were cues like that we were able to pick up through the call listening that I don't know that we would have identified otherwise. And so really understanding what your seniors need is a key component of an overall successful strategy and program. Last slide, I think. So what lies ahead? It is not an easy time to be in this business. We are seeing significant disruption in the Medicare Advantage market. I mentioned the boomers turning 80 in 2026. That's a very different cost profile than 10 years ago. CMS is refashioning stars and risk adjustment and evaluating what does it mean to be sustainable, but we also want to make sure it doesn't have a perverse approach on our older seniors. So as we think about, again, there are certain star clinical measures that they are not eligible for. How do we ensure we have the right balance, that we're incenting for quality and in a way that is appropriate for an aging population? And then, of course, there's the steep escalation of pharmacy costs. And so as I'm working with my team, as I'm talking with others in the Medicare Advantage market, I do think that MA serves a very core function. This is a big challenge we are all facing. I don't think there is any one area or sector of the community that is going to have the solution, but I think that Medicare Advantage plans can play a key role. However, we have to be very disciplined. We can't chase the market, and by that I mean you don't have to offer a whole laundry list of everything under the sun of supplemental benefits. What are the benefits that are most impactful for the members that you're serving? And the outcomes you're working to achieve? How do you collaborate with providers as well as pharmacists and other community partners? I didn't touch a lot on housing, for example. We have a lot of strong grants and funds out there when it comes to addressing housing needs, particularly when it comes to housing maintenance, which is a big key issue we have in the Philadelphia area, or putting in ramps. We've got a lot of row homes with steps, steps to get into, steps to get up to the bedroom and the bathroom. How are we working with our community partners so that our seniors know how to find those resources versus embedding them always in the plan ourselves? And we have to be ruthlessly performance driven. That we are stewards of taxpayer dollars. And so how are we making sure those investments are paying off in the way that we need them to when it comes to outcomes in the long run? So that was just a high level example of some of the things that we are doing and working on to get, I won't say perhaps in front of, because I feel like it's already here with boomers turning 80, but be in lockstep with others as we work to address the challenges that come with a rapidly aging population. Mm-hmm.
Great. Thank you, Kortney, for highlighting some of Independence's approaches, including the post-acute care program and your focus on supporting the caregiver workforce. We'd like to use the remaining time for Q&A, so we'll invite all of our panelists to come back on video. We have a few minutes left, so I'll try to move quickly. We talked about the caregiver workforce. We have had some other questions come in around the workforce, the clinical workforce more broadly, and the sustainability of the workforce as we're seeing shortages in workers or maldistribution of workers. What is the impact of this on care for the older populations? And especially as we're seeing these numbers increase, can anyone speak to this, or are you aware of strategies or solutions that are being implemented that you could quickly highlight?
Yeah. I'll go a little bit. I think it's significant. I think for just one example, around 30% of our members still see an independent primary care physician. So think, sort of mom and pop on the corner. Many of those primary care physicians, actually a good 40% of them, are 65 and older themselves. So a high likelihood in the next 5 years that they're going to retire. And so where are those members going to go to receive care? I don't think there's any one panacea solution. We have worked with multiple partners, new types of provider models, both store as well as sort of virtual, storefront, if you will, box providers, as well as virtual in-home provider partners. I don't know that any of them have the secret sauce yet, partly because there's some hesitancy, at least I have seen in our area, of them leaving their mom and pop providers that they've known for 20, 30 plus years. However, investments in those types of unique provider engagement paths, I think, are the right thing to do. I do think they will eventually pay off. We just have to be patient and continue to pilot and invest.
Great. Did anyone else want to answer that one? No? All right. We also had a few questions come in around the role of technology or AI, and I know Kortney touched on this a bit in her presentation, but wondering if either of the other panelists wanted to talk a bit more about how you see the technological advancements serving this population, or why it is important to have strong data as we are moving forward with some of these advances that we're seeing in AI and technology. I'll open this up to any of the panelists.
I don't know that I can speak to the AI part of it, but certainly from a data perspective, the more that we can understand what benefits our members are using, which ones they're not using, what value they're getting out of them, how that's impacting other healthcare needs and utilization, the more we can improve the benefit offerings that we have for our members. So I think certainly data is a very important part of how we design and continue to update and keep our benefits kind of best matched to the needs of the population.
And then I think to the degree to which we can ethically apply AI and appropriately apply AI can also, in theory, help address some of the bandwidth challenges that we're going to have as a country overall. What's the best site of care? What's the best method of engagement? How do we, is there possible to have an AI outreach first instead of always a live nurse? But then how does that transition? Because I do wholeheartedly believe that ultimately care is personal. And so there's got to be a person somewhere along the line. But I do think the ability to unearth trends quickly, as well as sort of expand capacity, are two key opportunities as we think about AI.
Great, thank you. Well, unfortunately, we are out of time, so I would like to thank our excellent panel of speakers for being with us and our audience for joining in on the conversation today. I will note that a survey will open on your screen at the end of the event. Your feedback is very important, so please take the time to fill that out. And we also have some other resources available on our website, as well as all of the speakers' presentations. Thank you all again for joining us today, and hope you have a great rest of your afternoon.